Live from Boston, my name is Emilio Madrigal, and today is July 14, 2020. I am joined remotely by my good friend and colleague Rafat Manan, who is in Philadelphia at the University of Pennsylvania. Today, we are excited to once again welcome back Dr. Neil Theise. And, Dr. Neil Theise does not need any introduction, but I will mention, as many of you know, Dr. Theise was the first presenter on Pathcast, and that was over 3 years ago. So it's always very exciting to welcome back Dr. Theise. He's a professor at the Department of Pathology at NYU in New York City. And today's lecture is a liver pathology lecture, and the title of that lecture is Regression of Fibrosis in Chronic Liver Disease, the Beijing Classification. As always, please post your comments, questions in the Facebook and YouTube chat windows, and we'll definitely make sure to pass those to Dr. Theise at the end of the lecture. So with that short introduction, I'll just pass the microphone over to Dr. Theise.
Thank you, Emilio. Thank you, Rafat. As always, I'm so proud of you guys, what you've made after that first crazy little lecture we did. Good morning from New York, everybody. It's a really nice summer morning, starting off cool here in New York City. And actually kind of looks, I'm looking out the window right now, it looks very much like the picture. We're going to talk about liver fibrosis, and we're going to talk generally about mechanisms as we now understand it from a pathology standpoint of how scarring in the liver is thought to happen, particularly in hepatitic diseases, though this probably applies to all diseases in some significant measure. And then how we now know fibrosis can regress, which was once a challenging and even mocked idea when it was first proposed from a pathology standpoint by Ian Wallace over 20 years ago, nearly 25 years ago, I think, but now is well recognized. And so we're going to talk about that largely in the context of viral hepatitis. I'll focus on hepatitis B and C, for which we have some hard data. But I'm certainly open to questions about how this may apply to other diseases, because it's work that needs to be explored. So the Beijing classification is a new classification, a new staging system of for viral hepatitis. We first published it with colleagues of mine from Beijing Friendship Hospital, and so that's why we called it the Beijing classification. And I'll describe how we came to this. This is the original paper. We have subsequently, this is a clinical paper in hepatology. We subsequently wrote this paper for Modern Pathology. These are the primary authors involved in development of the classification. Eileen is in Singapore. Hong and Yameng and Jidong are hepatologists at Beijing Friendship Hospital. And so this is a paper that looks at it from the, this paper looks at it from the clinical side. It's based on clinical data. This is a summary and review of it, both the concepts of progression and regression, as well as how we use the Beijing classification, presented for pathologists in Modern Pathology the year after. I really recommend looking at this if you deal with viral hepatitis biopsies particularly, but liver disease in general. Take a look at this paper for the general concepts and start to see how it applies to the material you're seeing clinically and how it helps you advise your clinicians about the dynamic progression or regression of scarring in their patients. And if you're academically oriented, please do studies. There have been a few independent groups who have now used it in China, in Korea, one paper from Mount Sinai here in New York, where it's turning out to have useful clinical correlations. So I encourage you, if you're academically oriented, see what it looks like in your material and play with it and see if you can apply it in a meaningful way. So the history of this, why do we have another staging system? So there's a history of why we have grading and staging systems in liver biopsies and viral hepatitis. It goes back to 1968, which was the year of the discovery of hepatitis B. Guys, can you hear this? My window's open. Do you hear street traffic? Do I need to close the window? Rifat? Emilio? I guess not. So in 1968, hepatitis B was discovered, and autoimmune hepatitis had already been defined. And the big question back then was, if you have either of these diseases, what's the prognosis? Are you going to progress to cirrhosis, or are you going to be okay for the long term without progression? And so the question on a biopsy was about prognosis. And this is sort of the way.
Good. We're good.
You're good? Okay, great. Thanks. So someone might get hepatitis, what was then known as non-A, non-B hepatitis, or hepatitis B, or autoimmune hepatitis. And if they progress to chronic hepatitis, you would see chronic persistent hepatitis with very little hepatocyte injury, chronic active with interface hepatitis, and chronic lobular hepatitis with a lot of lobular activity. And these were prognostically important because if you had very little hepatocyte injury, no matter how much chronic hepatitic activity you had within the portal tract, no matter how much mononuclear infiltrates, progression of scarring was very unlikely. But if you had interface hepatitis, the risk for progression to advanced stage, end stage liver disease was significant. It wasn't always clear about chronic lobular hepatitis, and it became a little more clear when we learned eventually in, I guess, 1999 it was, 1989, that most of these cases were hepatitis C. And we know in hepatitis C, the amount of activity does not correlate with progression of scarring. And so that's why it was a dotted line back then. So like I said, the issue here was prognosis on the basis of how much inflammation you see. They either are likely to progress to advanced stage or end stage liver disease, or unlikely to progress. But once we had identified hepatitis C, and that became a predominant aspect of clinical practice, and increasing because of drug use in the 60s and 70s, intravenous drug use, mixed viral infections, B plus C, B plus delta, B plus C plus delta, then the needs for the biopsies changed. And there was a proliferation of schemes. These are some of the most prominent ones. There's the original Ishak staging system, and then a modification of that actually I sort of cobbled together, similar to the Batz-Ludwig, and then Medivir came out. And the issue here was because most of our cases were mixed or hepatitis C, pushing hep B and autoimmune hepatitis a little bit into the background in terms of daily biopsy practice, the grading of necroinflammatory activity and the staging of progression were separated from each other, because in mixed infection and in hep C alone, the grading, the severity of activity was not prognostic. Some with a lot of activity would scar, some with a lot of activity would not scar. Some without activity would scar, some without activity would not scar. So rather than get a prognostic system, we simply had a descriptive system. And that evolved into a system where people could base treatment recommendations on it, because the treatments for hep C and mixed infections were not good. So, and very harsh. So who really needed to try to go through that process became the question. And the key feature was, is there scarring or not? Someone who on a first liver biopsy isn't scarring very much, well, they're not really at imminent risk of end-stage liver disease, so you could wait for better treatments to come along. Whereas someone on their first biopsy who's already got advanced stage, that's someone you probably want to treat because they're already progressing. You can see the progression happening. And so this is the way those systems looked. And, you know, one of my bugaboos for many, many, many years, a bugaboo I received from Peter Scheuer, my mentor, who was part of the group that created the Ishak staging system, is that we have numbers that are assigned as labels to histologic features. And depending on the staging system you use, the same number may mean something completely different. So a 2 in the Batts-Ludwig or modified Ishak system is a fibrous septum, whether it's focal or frequent. In the Ishak stage, there are no fibrous septa for stage 2. There's just portal fibrosis of most portal tracts, one being a few portal tracts. And then in Medivir, it is fibrous septa, but specifically focal, not frequent. So the same number is meaningless unless you name the system. So if your clinician still wants you to be applying these systems, to give a number without saying what the staging system is completely confusing. And in my reports, I actually give all three. And this allows, and the diagnosis is, for example, chronic hepatitis, mildly active with focal fibrous septum formation compatible with hepatitis C. You know, typical from the days when we were biopsying all the hepatitis C cases. And I wouldn't put a staging system in the diagnosis. It's a note at the bottom, and I'd say modified Ishak stage 2, Ishak stage 3, Medivir stage 2, that kind of thing. But as you all know, with the advent of curative therapies for hepatitis C, the need to biopsy patients went down significantly because the treatments are exceptionally effective. They're minimally disruptive. They have very few side effects. They're safe, and you can cure it. So it doesn't really matter what their biopsy looks like. What you need to know is, do they have hep C? You answer that question clinically. You put them on the drug, end of story. So I'm sure most of you, like me, have seen their hepatitis C biopsies wither away, which is good, though not good if you're a liver pathologist. But now we've gotten into a new era where the questions then are different. And what information we need from liver biopsies is different. Primarily because we now have successful antiviral therapies. Not only do we cure hep C, but we can suppress hepatitis B long-term very successfully as well. And so, again, with safe and therapies that cause little trouble for most of the patients who go on them. So everyone gets treated. You don't really need to worry about it. But the new question that has arisen is that patients who begin treatment when they have advanced stage or cirrhotic liver disease, not all of them get better, even if you suppress the virus or cure the virus. Some percentage of them, like 10 to 15%, still go on to end-stage liver disease. And people thought for a while maybe this is because there's very low level or occult virus that persists despite treatment, but there's no evidence to suggest that's correct. And so the question that we tried to get a handle on in developing the Beijing classification was, could we predict in an advanced stage liver which ones are likely to get better and which ones are not? And so we had to start thinking about cirrhosis not being the same. Not only is a PBC cirrhosis different from a hep C cirrhosis, different from an alcoholic cirrhosis, so there's no such thing as cirrhosis. That's a whole other lecture I could give you. And if you guys want me to at some point, I can give you that lecture. But even within hepatitis B or hepatitis C, not every cirrhotic is the same. An early attempt to deal with this came from the Lannec Hepatopathology Society, founded by Ian Wallace, and who's really the father of the concept of fibrotic regression in liver disease, which I'll show you shortly, his ideas. And he founded the Lannec Society and developed this staging scheme as a collaborative effort of members of the society. So it's called the Laennec staging system. It was published in 2011. So this goes back a ways. We were already worrying, not worrying, we were already considering how the same disease could cause cirrhosis that was different in different patients. And how do we distinguish those different types of cirrhosis, degrees of cirrhosis? And so they came up with this idea of the amount of collagen deposition in the liver. And so here you have H&Es, and here you have trichrome stains, and you see that there's a little blue here, an intermediate amount of blue here, and a lot of blue here. And they called these Laennec stage 4A, 4B, and 4C. 4 for cirrhosis, 4A for mild amount of collagen deposition, intermediate, and severe. And the importance of this in this initial study was that there was really good correlation between the Laennec staging system of cirrhosis into A, B, and C with the hepatic venous wedge pressure taken at the time of liver biopsy. And this is a direct measurement of portal hypertension, or portal venous pressures, I should say. And you can see that there is a good correlation that if you have A, you have normal range portal pressures. The more collagen you get, the worse it gets. This is in parallel to concepts at that time. This is from a clinical group, Lupe Garcia-Tsao from Yale, Scott Friedman, who's sort of the father of hepatic stellate cell research, John Iredale and Mario Pinzani in Europe. And they wrote in Hepatology in a commentary that there are many stages of cirrhosis, and talked about compensated, stage 1, compensated, stage 2, but they have signs in terms of varices, they might have bleeding, and decompensated where you have end-stage liver disease. And these correlate with Ishak staging. In Ishak stages 1 to 4, so no portal fibrosis, some portal fibrosis, some fibrosepta, frequent fibrosepta. They are not cirrhotic. They have no symptoms of cirrhosis. And biologically, what's going on there is progression of scar. When you get to transition to cirrhosis or incomplete cirrhosis, Ishak stage 5, you're getting into this category. But there's no distinguishing between these and Ishak 5 and 6. There are no pathologic correlations to map these to each other. And that's what the Laennec staging system is trying to do. And you see, none of these address the question of regression, which is kind of funny because Dr. Wallace is sort of the father of the concept of fibrotic regression in chronic liver disease. This is a diagram of his from his first paper in Archives Pathology of Laboratory Medicine in 2000. And this was an extremely controversial paper, and really, I encourage you to go look at the original publication as an aspect of liver pathology history, medicine history happening as you see it. This paper was originally submitted to all the high-level liver journals, and it was rejected because fibrosis can't regress. That was the dogma. If you're progressing to cirrhosis, it's an unstoppable process. He looked at patients who were treated with, I think it was lamivudine, so the early successful suppression of hepatitis B, and some of those patients looked like they were regressing their scarring. And so he explored what that looked like and came up with descriptions of what that looked like, and eventually came up with this scheme. Failing to get it published in a high-level clinical journal, he ended up sending it to here, which is a solid journal, but it's not a clinical journal in liver disease. Impact factor, it's below where a paper like this you might have expected it to go. It was sent out to 4 reviewers, each of which recommended rejecting the paper. And but the editor-in-chief felt that this was Ian Wanless we're talking about. Even if you disagree with him, his methodology is so careful and he is so rigorous that you can't just easily reject something like this out of hand. So what he invited them to do is he would publish the paper over their objections. Each of them would write a commentary explaining why they felt it should be rejected, why they didn't believe it. And then Ian would write a response to them. And so in this volume, you have all of that published in a single volume. And it's really kind of fascinating as a history of medicine thing. So basically what he was saying is you start off with a normal liver that he schematicized like this: portal tracts, portal vein, bile duct, hepatic artery, terminal hepatic venules, moving into larger scale central veins that eventually drain out. And he postulates that in every liver disease, you get bystander or direct hit injury to the blood vessels. And as they become thrombosed in response to the injury, if you have 2 hits, inflow is compromised and outflow is compromised, then you get an area of what's called parenchymal extinction, an area of parenchyma which has no blood flow coming in and has no blood flow going out. The 2 hits are important because let's say you had no blood flow coming in, but you still had drainage. Well, if these were open, then you could still get collateral flow from sinusoids in areas adjacent. It's when you block off both the inflow and the outflow, you get parenchymal extinction. And it could be involvement of the artery as well. This just demonstrates it with portal vein, which seems to be more common in most diseases, and the terminal hepatic venules. This activates stellate cells within the area, and inflammation and ductular reactions, and all of that leads to the laying down of scar. Structures start to pull together as scar contracts. You get fibrosepta. So this is what it looks like in active disease. And with these distortions in architecture, you get further distortions in blood flow. And so you have this forward feedback loop that leads to more parenchymal extinction, more scarring, more distortion, more parenchymal extinction, et cetera, and you wind up having an advanced stage liver. Now let's say you stop the disease. You stop drinking. You cure the hepatitis C. You suppress the hepatitis B. Then the inflammation diminishes. The vessels that were thrombosed, they disappear into the scar, and vascular relationships start to reestablish. Blood flow starts to normalize in the absence of ongoing injury, and you get regeneration of hepatocytes and condensation of the scar. And as the regenerating hepatocytes start to push against that condensing scar with increasing elastin fibers like old scar does, and they start to release metalloproteinases which digest the scar, and you start having a restoration of normal vascular relationships, although you see that you have what Ian called portal tract remnants. They're not really complete portal tracts. And this, while it might look histologically like a portal vein as part of a portal tract, it's actually an adhesed central vein to the portal tract in which the portal vein has disappeared. So you see, we go from progression with active inflammation, vascular injury, thrombosis, and active scar formation, and then you interrupt the disease process by whatever means. Inflammation goes quiet, thrombosis diminishes, and then you get a restoration of functioning. So progression and regression. If you have up to the most recent edition of Robbins, there's a variation of this diagram in those books too. In the Modern Pathology paper, we illustrated it like this. You have, a schematized, over-idealized look at what the liver is. Humans are not hexagons, but it's a traditional way to describe it. And you wind up with vascular thrombosis, 2 hits, leading to zones of parenchymal extinction. Collagen starts depositing in those. And like any scar, as it contracts, elastin fibers start to deposit. So if you do an elastin stain, they become increasingly filled with elastin. And as inflammation diminishes, the inflammation within the septa diminishes, the ductular reactions within diminish, the edema, the congestion diminish. It condenses down into thin, old scars that eventually digest away. And while it may look like a normal liver, if you look closely, you see that, in fact, there are distortions that are a reflection of the prior injury. Progression, regression. And you can see that a progressing, developing fibrous septum looks very different from a regressing, disappearing fibrous septum. So Ian, in that original paper, described the hepatic repair complex, and in 3 categories of findings: fragmentation and regression of scar, which I'll show you pictures of. So here's an old fibrous septum. It's densely compacted and it's fragmented. Hepatocytes are interrupting the scar. This isn't a new scar forming. How would this piece know that this piece was here and that these pieces were here and that they would all line up and aim at each other? This is something that existed in a bigger swath, and now as that condenses down and starts to disintegrate, you're left with a linear array of septal fragments. Sometimes in liver biopsies post-treatment, you see things like this. That's the remnant of a little bit of scar, of a fibrous septum. Then there's evidence of the prior, now resolving vascular derangements. As I mentioned, portal tract remnants, hepatic veins with prolapsed hepatocytes, I'll show you, and aberrant parenchymal veins. So here's a portal tract, but there's a bile duct, an artery, and there's no portal vein. So it's a remnant of a portal tract. And here you can see, oh, this is probably a remnant of a septum here. And this is probably a central vein that was adhesed to the septum. And you can do glutamine synthetase staining to support that idea if the vein has a glutamine synthetase around it, indicating it's a central vein, not a portal vein. Sometimes you see the remnants of a wall of a central vein. These are not scar. These are the normal supportive buttons of collagen that support the architecture of an hepatic vein. And you can see hepatocytes prolapsing into the vein. And this is more common in a regressed cirrhosis. And here again, you have a central vein adhesed to a scarred sclerotic portal tract and fibrous septum. Notice that while it's wide, it's pretty acellular. So depending, the width of the scarring depends to some extent on the scale of the parenchymal extinction. But this will, over time, shrink down as more elastin tissue gets deposited and eventually degenerate. And then there's parenchymal regeneration itself. He referred to this as hepatocyte buds, and you can see evidence of this in a lot of biopsies. If you look carefully, I saw a little bit over here. This is work from my group showing that what he intuited were regenerative processes. We confirmed with 3-dimensional reconstruction. People used to think these were hepatocytes trapped in scar, but in fact, they're newly created hepatocytes deriving from stem cells within the biliary tree. And those are referred to as hepatocyte buds. So here's what it looks like in alcohol. And the reason I have this sequence is because of the clinical situation in the third picture, which I'll show you. This is what an active drinker's liver looks like. Like with fatty liver disease, non-alcoholic fatty liver disease, often an advanced stage, there's not much steatosis, and you have a classic Laennec cirrhosis, meaning micronodular, all the nodules are less than 3 millimeters, and you have very wide areas of parenchymal extinction with scar, the fibrous septum. You can see how cellular they are. There's congestion, there's edema, there are ductular reactions in here. This is someone who dies with active drinking. This is a liver from someone who was abstinent for 6 months to a year in preparation for getting a liver transplant. because it used to be that if you were actively drinking, you could not get a liver transplant. You had to demonstrate sobriety for at least 6 months. And when we got those livers at explants, they didn't look like they did in an active drinker. You still see some areas of wide active parenchymal extinction and scar, but far and away, you see much more these old, dense, fragmented scars that are thin. And if you stain for elastin, they're rich in elastin fibers. And you can see this was probably a nodule, this was a nodule, this was a nodule. And so the micronodular cirrhosis starts to transform into a mixed micro and macronodular cirrhosis in a regenerating liver. But still, these got transplanted. These were people who were going to die if they didn't get a liver. And so, there's regression of scar here, but was there a regression of cirrhosis per se? Is it clinically significant? They all needed a liver transplant anyways. And then I got this liver, this was about 20 years ago, from someone who had been an active drinker, had been in the intensive care unit for ascites and bacterial peritonitis repeatedly, but donor livers never came available when she was in the ICU, and with supportive care each time she got better and was sent home. She was terrified of the fact that she had end-stage liver disease. She stopped drinking, truly became abstinent. And back then, we didn't have a clinical system for deciding who needs a transplant. It was largely based on how much time you were on the transplant list. So she kept coming in with these episodes of ascites and SBP, but never got a transplant when she needed it acutely, but eventually accumulated enough time, 4 years, to rise to the top of the transplant list, and she got transplanted. When I got the liver in the path lab from the explant, it looked grossly like a normal liver. And when we looked at it histologically, we saw this, what used to be called incomplete septal cirrhosis. The old terminology suggested that this was a liver that's becoming cirrhotic. But this is a patient who had stopped drinking 4 years before. And when I looked in our records, radiographically, she had been fully cirrhotic, and we had a biopsy where she had been cirrhotic. And when we looked at the record of her episodes of ascites and SBP, it was first every couple of months, then every 3 to 6 months, and then in a year. And in the last year and a half, she had been completely healthy. So because we didn't have a concept of the possibility of regression of scar and regression of cirrhosis, she actually had a normal functioning liver and didn't need this liver transplant. But those concepts didn't exist back then. But you can see how this could progress to this, could regress to this, and regress to this in the absence of drinking. And when you look at any liver that's advanced stage, or what we call cirrhosis, you always see some areas look like they're new progressive areas of parenchymal extinction and scarring, and other areas that are regressing scar without active fibrosis, densely compacting, starting to fragment. And this is something Ian really emphasizes that's a key concept for this talk. There's always progression and regression going on at the same time. The whole liver isn't doing the same thing. An area that's more currently injured is progressing, but an area that was injured 3 years ago, 5 years ago, is undergoing regression. So there's this seesaw. It's the overall balance between progression and regression that determines how this liver is going to do, how it is doing, and how it's going to do in the long term. And now when you look back at the Lennox system, you notice that, oh, there's something else going on here. It's not just the amount of collagen. The implication of the original Lennox staging is that A goes to B, goes to C. But now I've shown you what regression looks like, and you look at this and you realize, wait a second, this looks like regression. It probably was 4B goes to 4C, and with the interruption of disease goes to 4A, with restitution of normal blood flow and loss of the portal hypertension that defined a more advanced stage. So the Lennox system isn't quite capturing the dynamic here, although you can see an aspect of it in the system. So at this point, we know that we need a staging system that clinically can distinguish different subcategories within advanced stage cirrhotic liver disease. The system has to be able to distinguish and quantify features of regression versus progression, and what's the balance between them. And now we're back to prognosis, because the question is, if you have an advanced stage hep C or hep B or alcoholic, and you successfully stop the disease, 10 to 15% of patients don't get better and still will need a liver transplant. Otherwise, they'll die. Which of the patients who get successfully treated will still progress? We don't know. And so what we'd like to have is, we don't need the biopsy so much in the earlier patients because everyone's going to get treated. But in the later patients, is there a way to distinguish who will improve after treatment and who won't improve after treatment? And the way to answer that question is to look at a pre-treatment biopsy and a post-treatment biopsy, because we really don't know where the prognostic information is going to be. Is it something different in the biopsies before they get treated, or is it something that we see manifesting in the biopsy after the treatment has been successful? We don't know. So that was a question that we decided to explore when I was invited by the team at Beijing Friendship Hospital to come to China for the first time, which was, needless to say, very exciting to me. And what they had a vast collection of clinical material for us to play with. And the first couple of days we were deciding, what are we going to look at? And then decided to sort of focus on this question. And we looked at it in an open-ended sort of way. We did not have a staging system that we had conceived of and then we're going to apply. We were going to see what the material showed us and then try and develop a staging system that made some sense. So we started off with hep B patients with paired pre- and post-treatment biopsies after 78 weeks of entecavir therapy. We had 112 patients with pairs of biopsies. Some of them didn't have adequate material on the pre or post, etc. Some didn't have any scarring at all, and those weren't useful to look at. So we wound up with 71 pairs of biopsies in equal numbers of pre-treatment and post-treatment. And then we started to look at them at the microscope. And what we noticed is you could sort of tell at a glance at low power when there was predominantly regression and when, sort of a Linac 4A, and when there was predominantly progression, a Linac 4C. And it turned out it was a really easy assessment. So in the first morning, we started noticing this, and then we invited a couple of hepatologists in the room, and even they were able at a glance to distinguish them. So we thought, oh, we've got something that's going to be simple and useful. And this is what we sort of came to. A progressive septum is broad, it's congested, it's often inflamed, it doesn't have a lot of elastin fibers in it. If you stain for smooth muscle actin, you see a lot of activated stellate cells. There are often ductular reactions within them. And you can recognize it whether you've got a trichrome stain or a reticulin stain, or frankly, even a PASD stain is really useful if those two stains haven't worked. And then, oh, these arrows migrated, I'm sorry. And here you've got a regressive septum, and here are fragments of another regressed septum with a portal tract remnant here. And these arrows are supposed to be marking these fragments of a fibrous septum, which on a deeper level, it's a continuous septum. So, where you're sampling and how much you dig into the tissue on a lesion by lesion basis can change things. Though overall, although this is a formal study of this has not been done yet, that would be a good project for somebody. Pretty much the grading, the staging of regression versus progression is the same over serial biopsy levels. And so you can look at low power at a liver biopsy. Here's the H&E, trichromes, and reticulin. And H&E, I wouldn't do my analysis there, though you can start to get hits of it. But with the trichrome and reticulin, you see that almost every fibrous septum is broad. These are all active zones of parenchymal extinction, inflamed, ductular reactions, congestion, edema, etc. After treatment, predominantly regressed. You see just remnants of fibrosepta, and everything's very thin. And then over here, well, is it predominantly regressive or predominantly progressive? We originally thought we should have a 5-point scale from fully progressive to fully regressive, but that was just confusing. And what we settled on was a 3-point. And again, it's really very simple. If you find yourself going to higher power to try and determine, in a case like this, was it mostly regressive or mostly progressive, the moment you feel like you can't make an assessment at low power, that's an indeterminate. The balance is so close you can't really say which is predominating. And so we came up with this PIR assessment, where we're looking at the qualities of fibrosis, not just the amount of fibrosis. So all the traditional staging schemes before are based on how much collagen there is, how much scarring there is. Portal fibrosis to fibrosepta to incomplete cirrhosis to cirrhosis. It's amount. Now we're talking about not just the amount, but we're talking about the quality of the fibrosis. Is it progressive in nature or is it regressive? And so here's the PIR score. I'll come back to the Beijing classification, also has simplified hepatic and fibrotic staging. I'll mention that briefly at the end, but this is the signal innovation, the quality of scarring. Predominantly progressive, indeterminate, regressive. And as I said, predominantly progressive, 4B or 4C Linac, maybe 4A, but that's controversial. This is an issue Ian and I have discussed. But predominantly regressive is clearly Linac 4A. And here are more examples using a reticulin stain. And you can see at low power, it's really at a glance. I'm sure each of you at this point, when I put the slide up, if you were still awake, depending on your time zone, you looked at these, you would have said, oh, progressive, regressive, somewhere in between. In the Modern Pathology paper, they wanted us to be a little bit more explicit than just showing those low power images. So they had us actually label progressive versus regressive scarring, and we did that. And you see predominantly progressive, there are more P's than R's. Predominantly regressive, there are more R's than P's. Indeterminate, it's sort of equal. But you've already seen that you don't need to label each one. You don't need to go to high power. You don't need to go field by field assessing what you have and counting how many are regressive and how many are progressive. You just look at it at a glance and you can see it. This turned out to correlate really well with clinical findings. At the time of biopsy, those who had predominantly progressive disease had higher ALT, AST, higher E antigen positivity, higher HBV DNA, and all these factors improve when you have more and more regression. In particular, liver stiffness measures. A progressing liver is stiffer than a regressing liver. And so this is reflected in places that are getting patients are getting fibroscanned rather than biopsies. There's a clinical correlate here. And in particular, patients who in the post-treatment biopsy showed predominantly progressive disease, their liver stiffness scores did not improve generally post-treatment. They bounce all over the place as a cluster. And these were patients in general who were getting worse despite successful treatment. Whereas those who had successful treatment and predominantly regressive features on the post-treatment biopsy, over time, the prognosis was they would get better and better. Their liver stiffness scores would go down and down back into the normal range. So this had prognostic value. When we sent it into hepatology for review, the only significant comment they had was they wanted a kappa analysis to see whether this was reproducible. If you know the history of the Medivir staging, it was developed as a replacement for Ishak because Ishak, the inter-observer variations were actually fairly significant, partly because when you have a 6-point scale, it's harder to get agreement. Smaller numbers of decision points give you better agreement than large numbers. But the Medivir staging system was entirely based on inter-observer agreement. And they had a kappa value for Medivir when it was first produced of 0.72. So they wanted us to do that. We went and looked at the methodology for the Medivir system. And the methodology there was they had 10 pathologists, liver pathologists, looking at 30 liver biopsy specimens. And they did inter-observer agreement for staging of F1, F2, F3, F4. And they got a kappa score of 0.72. So we did the same thing. We got 10 people in a room with 30 biopsies. They all looked at them silently at the same time. And we got the same kappa score. The thing is that ours weren't liver pathologists. I don't remember exactly. It was something like 2 liver pathologists, 3 general pathologists, 3 GI pathologists, 2 general pathologists, a hepatologist, and an engineer who wasn't actually a doctor. And with that range of skills looking in the microscope, we got superb inter-observer agreement. So all of you should be able to apply this easily. And the most important thing about it is displayed in these cases. This is an Ishak 6 Linac 4C stage liver biopsy. After treatment, still Ishak 6, it's still cirrhotic, but the patient's doing better. The Ishak staging does not capture the improvement. You need to talk about going from predominantly progressive to regressive. And the Linac isn't really helpful here because while it does reflect that, it implies the Linac system says this is the early lesion. That's why it has the letter A, when in fact the A is coming after being C. So rather than use letters that are sequential, implying directionality that can be confusing, simply predominantly progressive versus predominantly regressive. The same patient, pre-treatment, post-treatment, same stage of disease. For a clinical trial, this means there's been no improvement. But there has been improvement. This is predominantly progressive, and this is predominantly regressive. So this has important applications for seeing whether clinical trials are successful. And we're hoping it gets picked up for that use. I'll skip that. It's a bit complicated. And this I've already discussed, how it maps to the Linac. As I said, the other systems, we replaced them because hepatitis assessment, the degree of necroinflammatory activity, isn't so important anymore. It's not prognostically useful. It's not going to determine who gets treated. So why do we need 4-point systems or greater? So we turned it into inactive, active non-severe, active severe. And severe is defined as the presence of confluent necrosis. So confluent necrosis is dropout of hepatocytes around the central vein, to bridging necrosis, to parenchymal collapse. If you see these in a biopsy, it does have clinical significance, whether the patient is being treated or not. Here's perivenular confluent necrosis, bridging confluent necrosis. And if you see these in a Hep B patient, it might simply be a flare of activity at the time of E antigen to E antibody conversion. But it may be that the patient has hepatitis D that no one's picked up on. It could be that they've had HIV co-infection that isn't treated, that no one's aware of. I've had 2 patients, I've seen confluent necrosis in viral hepatitis, and they turned out to be untreated HIV with diminishing T cell counts. It could be concomitant autoimmune disease. It could be concomitant drug or toxin-induced injury. So it's important to recognize that. We include that in the Beijing classification. Same thing for hepatitis C. The finding of confluent necrosis, active and severe, has clinical significance. The fibrosis stage also, we don't need to be distinguishing 4 or 6 features. The real question is it early, intermediate, or advanced? That's sufficient clinical information for clinical trials and for clinical practice. So that can be simplified and improve inter-observer variation. And that's kind of it. I'm happy to answer questions.
Thank you, Dr. Theise, for your excellent discussion on regression of fibrosis. There are a few questions that I see online. And one question is that, first of all, uh, the viewer compliments you for this excellent discussion and wants to know if the regression of portal to if the regression of fibrosis applies also for biliary type of fibrosis.
Excellent question. We kind of don't know because we don't get successful interruption of disease, really. Maybe in someone with PBC who is diagnosed with a more advanced stage, who gets put on URSO, might regress, but those are not patients we see biopsies of. We do know that most patients on URSO with PBC don't need to get transplanted. URSO is successful at slowing down progression or preventing progression. And so we don't have material to look at. PSC, we can't cure, we can't treat. So there probably is. Now, that all being said, if you get an explanted liver or a liver from someone who's been autopsied, and you in an advanced stage PBC or PSC, you will see areas of regression. As Ian indicates, it's always a balance. There's always regression and there's always progression happening all the time. So yes, in those livers, you can see evidence of regression, but is it something that's meaningful clinically? In the absence of real curative therapy, probably not.
Thank you. The next question is from Michael. I hope I would be able to read the question properly. So it says that, do you think the use of PIR score in clinical trials for compounds or drugs in liver disease can be better than currently used scoring system?
Yeah. And that's specifically, something we suggested. There needs to be follow-up studies to validate this. I'm actually involved in a study. We've got an agreement. Ira Jacobson, who's my hepatologist, chief of hepatology at NYU, he and I have worked out an agreement with Gilead where they're going to give us their largest cluster of, I think it's 500 patients with pre and post treatment liver biopsies with Hep B. And we're going to go back and look at that clinical trial cohort and repeat this. And it being Gilead and it being the largest study that established that regression happens and curative therapy happens, we're hoping that makes the point. As I showed with those two cases, it would, where you have the staging, Ishak staging is 6 and 6 pre and post transplant, and yet, so there's theoretically, by traditional ways of doing that clinical trial evaluation, there is no improvement. But clearly there's improvement from progression to regression. So it would behoove the companies that have anti-fibrotic agents to be using this as a criterion. I've given some talks on this at different companies that have anti-fibrotic agents. I'm not aware that any of them have yet added it to their clinical work. So, again, I think we need more validation studies, and I encourage people to do that.
Next question is from Pranita. So do you take biochemical studies also into consideration while discussing or talking about regression?
Yes, but some patients who truly regress, they completely normalize their liver tests. Some don't. There is some relationship between those, but as we know, serum measures of ALT and AST don't really necessarily correlate well with hepatitic activity or scarring. So, this is an argument for why we still need liver biopsies. The serologic studies do not replace what we do in looking at the tissue. But as you saw, sorry, but as you saw, this talk will be up. You can go back and look at that table of the clinical correlations from the original paper, and you see that ALT and AST are significantly lower in predominantly regressive than predominantly progressive livers, and indeterminate intermediate biopsies have an intermediate value. So there's a relationship there, but as with prior methods, it's not a tight correlation.
Right. On a similar note, the next question is from Maria, who is asking, so are your clinicians familiar with the PIR system?
Now they are.
And are they doing more liver biopsies as a result?
No, they're not, because this doesn't change as yet the clinical indications for doing a liver biopsy, but they are profoundly appreciative of the added information it gives them as to what's happening. And so they want to know progression versus regression. I include it now in all my reports. So as I said before, I list the Ishak, modified Ishak, Medivir. Now I do Beijing classification, and I say the PIR score aspect, predominantly regressive, predominantly progressive, indeterminate. And it's meaningful to them. They have patients who have liver disease where things are equivocal clinically. It might be something where they're not treated or partially treated, or a disease that has no treatment. And if I apply these, it helps them understand what's going on with the patient. And it certainly is interesting in patients who are post-treatment, as we focused on here in B, but also in C, that the ones who on a biopsy post-treatment, but their ALT and AST stay up, they're not doing better, then the clinical question becomes, well, do they also have fatty liver disease? Do they also have drug or toxin? Do they also have autoimmune liver disease? They get the biopsy, and we don't see any other liver disease, but we see is the same Hep B or Hep C associated kind of stuff, but continuing to progress despite the treatment. Then they know that's a patient they have to watch carefully, and maybe will still need a transplant, even though they are successfully treated. Another thing that started to emerge, there's a recent paper from Young-Yan Park and her team in Korea, Yonsei Medical College, where they show that recurrence of resected hepatocellular carcinoma is increased if the background liver is predominantly progressive versus predominantly regressive. So there is also an aspect where this touches probably on the risk of HCC, hepatocellular carcinoma, in patients who have been treated. Risk doesn't go to zero, but it may indicate those who have less risk and have to have less aggressive screening going forward than those who, or conversely, those who remain at significantly increased risk and have to have more aggressive screening than you might think, even though you've cured their disease. So that's another question that needs to be studied and explored.
The next question is from Satish. What is your experience of regression in autoimmune hepatitis?
We see it. We see it really beautifully. Successful suppression with immunosuppression, you see regression in those patients. And the Mount Sinai paper I mentioned touches on that lightly, but and again, it's something worth exploring. No one has studied it yet.
One question is from Ambaris. The question is, does progressive or regressive disease on a core biopsy represent the pathology in the entire liver?
As always, we're talking about statistical differences. No one has done a correlation study to show what's the minimal amount of tissue you need to successfully evaluate the PIR score. We're assuming it's similar to what was done previously for just regular staging. There are 3 studies, all of which show, between 2 and 3 centimeters is the ideal, under 1.8, too limited. But no one has done that statistical analysis. My guess is that it will be similar to the amount of tissue you need for classical staging systems.
There's another question from Emmanuel. So he says that if it is indeterminate, how do you communicate an indeterminate result to the clinician?
PIR score, indeterminate. Indeterminate for progression versus regression, or describe it as balanced between progression and regression. But the staging system is PIR. So if they are familiar with the staging system, they know the meaning of I.
Right. And here's the next question from Minesh. So do you take sinusoidal capillarization also while given weightage for PIR score?
No. Trichrome, reticulin, or like I said, PASD works fine too. It's a histochemical stain. If you want to study capillarization and compare it to P versus I versus R, that would be an interesting study to do. Maybe there'd be more information that would be clinically useful or useful in terms of pathobiology. But no, it is not part of the staging system. The staging system is based on histochemical collagen staining.
Right. There is one more question. So is there any changes in the liver parenchyma that can be correlated with progression or regression? So this question is from Gayatri.
You see more regenerative features in those that are predominantly progressive. But you see that in the hepatic repair complex of Ian's initial description, all he talked about was the presence of regenerating hepatocytes within fibrous septa. What's going on with the parenchyma has not, to my understanding, been well studied. The sinusoidal capillarization question actually would bear on that. Do you see more or less capillarization around regressing versus progressing fibrous septa? That would be a parenchymal sinusoidal relationship change, not a reflection of the quality of scarring. So open area for analysis. Again, I mean, you guys have come up, every question has been at least one or two good studies that are worth doing.
Right. Actually, on that note, there is another question that do microvascular changes also regress to some extent?
Yes, and so Ian talks about restoration of vascular supply, and that's probably the basis of successful regression. And unsuccessful regression is that there are so many vascular alterations and so much injury that even if the activity of the disease disappears, the vascular alterations, the vascular injury still progresses on its own. And that's what carries things forward. So yeah, it's probably entirely dependent or significantly dependent on whether you're getting restoration of vascular relationships or not.
So thank you. I think with that, we have come to the end of the question answer session, and there are some more questions. I think that we can answer them later. And if you have questions, you can reach out to us or Dr. Theise directly, so that Dr. Theise will be able to answer them at another time. And thank you, Dr. Theise, for this excellent discussion on the regression of fibrosis. And you would be really happy to hear that you had several hundred viewers from nearly 20 countries that I could take note, and especially Paulo from Philippines, say hello to you. And,
Hi.
And I think there is another, somebody from Singapore, Singapore, Leo Wei Quang, so who says hello especially to you.
Hello.
And so thanks to all our viewers for tuning in. And in fact, we have another podcast today at 12 p.m. Eastern time. That will be on microbiology, just a change in the topic. And with the boards on the horizon, so we thought that it would be good to discuss from some microbiology topics. And the speaker is Dr. Margie Morgan from Cedars-Sinai. So hope to see you all then. And in fact, Dr. Theise also plans to take another lecture on hepatic carcinogenesis. So that date hasn't been decided yet. We will let you know. And as always, if you like our lectures, please follow and like our Facebook page and subscribe to the YouTube channel. And also, please subscribe to our newsletter so that you can stay updated with all the upcoming lectures. And thank you, everyone. And thank you, Dr. Theise, for the talk.
Thank you. Thanks, everybody.